Hello, this is Dr. Ayub. So today I like to give you the idea about the ovarian pathology. Okay, so with the ovarian pathology, I think I will be able to complete the pathology of the female reproductive system. And after that, I will try to give a lecture on the infertility, because in the male and female reproductive organs pathology, that includes also the infertility, because a lot of couple, they are infertile for a long time, and they come to the clinic to rule out or evaluate the situation, and they want to know if there is any problem, so then we can correct it and we can be a father or mother. Okay, so that's the way the infertility, I'll try my best to give the lecture on it. But today I like to give you the idea about the ovarian pathology, and I just want to make share with you that I have an intention in near future, when I will have a handful time in my hand, I might do some charity of giving the online lecture, maybe on Zoom platform or Messenger or any other means. So that I like to give the lecture on the ultrasound physics and instrumentation, vascular board exam, that is RVT, and abdomen and superficial structures, OBGYN. Okay, so all those subjects I can cover in my online lecture that actually I will do for the charity. And in that charity, yeah, there is no fixed fees. There is no fixed fees. Whatever you want to share, that will be enough, because my intention is that if I have a good fund, so I might start doing some public library in my country, Bangladesh, in the rural area, so that I could be a little help for my country and the rural area and in privileged area. Okay, so that's my intention. So I hope you might think about it, and you might help me out about these things. Okay, so let's move on. The ovarian pathology, I classified here. I think it would be a little helpful, but you have to understand the classification first. Benign simple cyst, benign complex mass, then benign solid masses, primary malignant ovarian neoplasm, and secondary ovarian malignancies. Normally, we describe an organ with the pathology that there might be some congenital anomalies, there might be inflammatory condition, and there might be some cystic diseases of the organ, and neoplasm, mostly it is a benign and malignant. And malignant can be primary, can be secondary. Besides this, there might be some pathology due to trauma, and autoimmune and unknown origin. Okay, so that's the way we classify the diseases of the organ or the system. So here I like to go directly on to the ovary according to this classification. And in my previous lecture I discussed everything about the way I just said: congenital, inflammatory, cystic, and neoplasm, iatrogenic, and idiopathic, autoimmune, traumatic. Okay, so now ovarian pathology. So benign simple cyst. Benign means not malignant, not harmful, and the cysts are simple in nature. Why we call it simple? Because it maintains the 4 criteria. It maintains the 4 criteria, and those 4 criteria are: the wall should be thin, smooth and regular, and there will be anechoic or sonolucency in the center. There will be posterior enhancement and is refracting shadows. So these 4 criteria fulfills the simple nature of a cyst, and all those 4 cysts, they maintain that simple nature. What are those 4 simple cysts? One is a follicular cyst. We also call it functional cyst. That means that cyst, it comes from the Graphene follicle. So Graphene follicle is a pretty good size. Average is 2 centimeter diameter. And then ovulation takes place. So when the Graphene follicle is seen in full size, it looks like a cyst. Yes, it is a cyst. Do I need to measure? Yes, we need to measure. What is the size? 2 centimeter. Take the LMP history and we declare, oh, okay, it is a Graphene follicle or mature follicle, adult follicle is going to be ovulated. Do I need to check the endometrial thickness, uterus? Yes. Because you can understand the patient is in ovulatory phase by looking at the size of the follicle, taking the history of LMP, that is the first day of last period, and by looking at the endometrial thickness. And typically you might see the tri-stripe, triple line inside the uterine cavity. Okay, so follicular cyst also can be more than 2 centimeters. Sometimes the ovulation does not take place and it's growing bigger. It can up to 5 to 6 centimeters. And what happened after that? It leaks or ruptures. Okay, how do I know that it ruptured? Hey, look at the fluid amount or fluid content in the posterior cul-de-sac. If you see there's a fluid in the posterior cul-de-sac, and patients after ovulatory phase, the secretory phase, then we need to understand that this fluid came from the ovulation. Okay, and this fluid is blood mixed fluid, tissue fluid like. Okay, so follicular cyst in the ovary is very common, very common. So always take the history of LMP and check the endometrium. Follicular cyst can be big enough that looks like the whole ovary is taken. Whole ovary is taken by the cyst. Okay? And do I need to measure the cyst? Yes. Even the whole ovary is taken by the cyst, still you need to measure the ovarian dimensions and the follicles. You need to measure separate images. So your image number will be increased, and you need to measure sagittal view and transverse view. In the sagittal view, you need to measure the length and height, and the transverse view you need to measure the width. Okay, so that is follicular cyst, and I will draw that diagrams. Let me just give the idea first. Corpus luteal cyst. Corpus luteum. What is corpus luteum? When the Graphene follicle having ovulation, that means egg is out. Then when the egg is out, then the shell remain inside the ovary. And as soon as it leaks out and the egg is out, the shell get cracked and it heals quickly. And now there will be fluid and blood inside the follicle, and it looks like another cyst that is known as corpus luteum cyst. This corpus luteum cyst is very important. You need to know the characteristics of diagnosis that this is a corpus luteum cyst, not the other pathological cyst. Number one, take the LMP history. Understand the pregnancy test, beta HCG, and click the color. Click the color. If it is a corpus luteal cyst, you will see there is more vascularity around the corpus luteum, and the resistivity index to the ovarian artery is low. Okay? The resistivity index of ovarian artery will be less. Okay? So now blood will flow too much towards the ovary because this corpus luteum is active corpus luteum. And this corpus luteum is surrounded by the cells that produce two hormones, mostly progesterone and estrogen. This corpus luteal cyst, active cyst, is responsible for survivability of the pregnancy during the first trimester. This corpus luteum cyst will remain 10 weeks to 12 weeks, almost the first trimester, as a functioning if the pregnancy is sustained. And if the corpus luteum dies, early dying, so the progesterone level will go down and the sustainability of the pregnancy is questionable. Is questionable because the trophoblastic activities depends on the amount of progesterone that comes from the corpus luteum. And if the trophoblastic cells are dying or not growing, so pregnancy cannot have the what is this called? It's not sustainable within the endometrium. Okay, so the trophoblastic cells anchors the endometrium and it holds the blastocyst in position. That is called implantation. Okay, so for implantation and trophoblastic activities and production of the human chorionic gonadotropin by the trophoblast, the progesterone is needed, and progesterone comes from the active corpus luteum. So corpus luteum evaluation is very important. If the pregnancy test positive, come from the beginning. If there is a missing of period, pregnancy test positive, and the IUP, intrauterine pregnancy, viable pregnancy is there, but in the ovary, corpus luteum is not found or is not active. So the future of this IUP is questionable. It cannot be survivable. Okay, so that's why, do I need to measure the corpus luteum? Yes. How? The same way as the way you measure the cyst, the follicular cyst. What would be the characteristics of the corpus luteum? Corpus luteum characteristics will be, most of the time, the wall will be thicker and the size of the corpus luteum would be bigger. There might be internal echo because of the blood and blood clot, and hypervascularity around the corpus luteum. Okay, so this is corpus luteum. We need to evaluate. And the corpus luteum, if pregnancy occurs, so it will sustain for 10 to 12 weeks. If pregnancy does not take place, if fertilization does not take place, corpus luteum will regress. And it will turn into corpus luteum hemorrhagicum, then corpus luteum albicans. Finally, it will remain in the ovary like a dots, like white dots in the ovary. Okay, then the next cycle, that ovary will take rest. Other ovary will starts forming the Graphene Follicle. So ovary ovulates every other month. Okay, that we need to remember. The para-ovarian cyst. Para means by the side. Para-ovarian means by the side of the ovary. This para-ovarian cyst could be multiple, could be bigger. They are not inside the ovary. They might be attached with the wall of the ovary. Wall means the epithelial covering of the ovary. And these are actually the patent mesonephric tubules that form the collecting systems of the urinary systems, kidney. That remnant is supposed to be involute, but it did not. It persists, is live. And that small duct starts forming the fluid inside gradually and become cyst. And it could be bigger cyst, 20 centimeter, 25 centimeter diameter. And they are creating too much pressure in the pelvic cavity. It will give the pressure pain. But keep that in mind, it's not going to destroy the ovary. It will be attached with the ovary by the wall, but it is not inside the ovary. That's the way you have to be careful. During the ultrasonography, you need to evaluate it, whether it is inside the ovary or not. Okay, do I need to click the color? Yes, it is my policy. Whatever suspicious, it could be cystic, then solid, complex, simple, doesn't matter. I always click the color. Because sometimes color appearance can isolate a mass is separated from the organs. Okay, so that is important. Now, another one is the Serous Cyst Adenoma. Serous Cyst Adenoma, and usually it is in the group of simple, and the mucinous cyst adenoma, it belongs to the complex. Okay, so serous cyst adenoma, it is a cystic version of the serous adenoma. Okay, so now the fluid containing are two types, serous and the mucinous. The serous fluid is very simple, watery like fluid, water like fluid. Okay, like your tear, your parotid juice, those are the fluid, like a serous fluid. And the mucinous is slippery, then secretions from the throat. The stomach juice is slippery, right? Those are the mucinous, mucoid. So this serous cyst adenoma, it is an adenoma, but it is a cystic version. That adenoma, serous cyst adenoma, usually unilocular, and the wall is thinner, less than 2 millimeter, and uniloculated, should not have septation inside. No, it is simple like, and usually it is unilateral, about 80 to 90%, but it could be bilateral, 10% to 20%. Okay, so this serous cyst adenoma, it falls into the benign simple cyst. Okay, so these are the 4 cysts we usually may encounter in the ovary. Okay, in the simple version. And in the benign complex masses, the mucinous cyst adenoma, cystic teratoma, we call it dermoid, theca lutein cyst, and the polycystic ovarian diseases. Okay, we're going to discuss about it. Okay, so now I like to go over the simple, benign simple cyst with the diagrams first, then I will go this. Okay, so from this I like to take I need actually a space to describe this, so I'm going to take this part out. Okay, so but I believe you took note about these classifications. Okay, follicular cyst. So this is, I'm talking about the follicular cyst. Follicular simple cyst. We call it functional cyst. Functional cyst means the Graphene follicles. Okay, so if this is the ovary, we need to understand that ovary has tunica albuginea, that is tunica albuginea, and there is epithelium. Okay, so it has epithelial cells and a couple of cysts develops from these epithelial cells. And this is cortex. And this is medulla. You need to understand first that this cortex has primary follicles. It's a multiple follicles. Maybe 50,000 follicles initially are settled. So now primary follicle is turning into a mature follicle, Graphene follicle. Okay? So this is Graphene follicle. Graphene follicle. So these are the primary follicle. This Graphene follicle is, you will see, at the time of 14th plus minus 2 day of the menstrual cycle. This Graphene follicle remain inside the cortex, and there will be a ovum inside, but this ovum you're not going to see it. So now it will be totally anechoic inside. Okay, it will be totally anechoic inside. And this is ovary, and this is the Graphene follicle or mature follicle. Usually it is 2 centimeter dimensions. So when this follicle is normal and having ovulation, so there will be leaking, rupture of the membrane of the tunica albuginea, okay, and then egg is out. The egg is getting out with the cells around it, okay. And you know that corona radiata and zona pellucida, those are the cells layers are there. And now, as soon as ovulation is done, this wall will be sealed.